Not going to try to do a tour de force through all of upper GI, but really concentrate on pancreatic cancer and hepatobiliary and try to cover some things that hopefully are practice updates and would impact on your management of patients. I have no disclosures. So starting with pancreatic cancer, really want to focus both on adjuvant therapy and neoadjuvant approaches where most of the recent updates have impacted on our practice. I think everybody realizes for pancreatic cancer, our first evidence of any benefit for chemotherapy after surgery came out of the CONCO study. And the reason I show this, as you look at the subsequent studies that have been done, pay attention to survival, particularly with gemcitabine as the comparator arm. In this trial, it was 22 months, which was a modest improvement over observation alone, but did lead to the approval of gemcitabine in this setting. There was a separate study in Europe that looked at 5-FU and leucovorin using the old Mayo approach compared to gemcitabine and showed equivalent outcomes. In this study, the survival moved up slightly from 22 to 23 months. And then most recently, as published last year in The Lancet, there was a comparison of gemcitabine to gemcitabine and capecitabine from the SPAC3 trial. This again showed some progressive improvement, but notably again, if you look at survival for gemcitabine, it was at 25.5 months, saying that we're probably doing a better job of picking patients that truly had localized disease and might benefit from surgery as well as adjuvant therapy. As of last year, the use of gemcitabine and capecitabine became the new standard for patients going to surgery without any neoadjuvant therapy. And so that had been the standard up until ASCO this year when another study came out, PRODIGE 24, that looking at multi-drug combinations, in this case using a modified FOLFIRINOX to say, would this benefit patients following surgery? The trial randomized patients to either modified FOLFIRINOX or gemcitabine. And just of note, when you look at the study and its design, it included, which is appropriate, patients with either complete resection or microscopic residual disease. And importantly, the FOLFIRINOX used in the setting at the start of the trial was without bolus 5-FU, but otherwise standard doses in FOLFIRINOX. However, partway through the trial, the dose of irinotecan was reduced from 180 to 150 milligrams.